This is QD Clinic, and I'm Jack Cush with RoomNow.com. QD Clinic is brought to you by ACR IQ, a daily quiz during the ACR 2020 meeting where you can check out how you stack up against others. This is our last clinic, our last video that we're going to shoot prior to the ACR, so it's a good one. It's a brain thumper, stumper. It's called Running Out of Options. My patient's a 67-year-old man who has seropositive rheumatoid arthritis. I've taken care of him for about 6 years now. He also has some low back pain, degenerative disc disease, had knee OA that led to 2 knee replacements. And the sad, ugly part of the story is that he's had multiple prosthetic infections. And of course, he had those while he was taking biologics. So what has he been treated with in the past? He's been treated with the following: methotrexate, adalimumab, Humira, prednisone, Cimzia, Simponi, Otezla, Orencia, hydroxychloroquine. And we're now at a point where we don't know what else to use. Oh, he also took rituximab. On TNF inhibitors and methotrexate, he had 2 septic joints after he had his surgery. Both were MRSA. On, I think, rituximab and another DMARD, he had a candida septic joint. So you can imagine the surgeons are worried, the patient's worried, the rheumatologist is worried about what to use next. And yes, the man has active synovitis with 6 or more swollen joints, a bunch of tender joints. He's got a CDI score that's 21 today. He's currently taking leflunomide, gabapentin, trazodone at bedtime, PRN, Tylenol arthritis. Don't know that because his pain level's an 8, but he just takes PRN, Tylenol arthritis. He's not on steroids. So what do you do? What do you offer? At last visit, we talked about let's try to go after triple DMARD therapy. When we can't use methotrexate, he won't take methotrexate. We'll use leflunomide, hydroxychloroquine, and maybe we'll add sulfasalazine later. We gave him hydroxychloroquine, nausea, headache, couldn't take it, stopped it. He's generally not difficult when it comes to taking medicine. So if he says he has a side effect, I believe he truly has a side effect. So again, I'm stumped. What am I going to use next? We really can't use TNF inhibitors. So I've written about treating a difficult RA patient, and my solution is reboot, Control, Alt, Delete. What does that mean? Delete, number 1, the medicines you can't take or the patient won't take. That includes methotrexate, Humira, Simponi, TNF inhibitors, Otezla, Orencia, and hydroxychloroquine. What controlled him in the past? Well, actually, the TNF inhibitors and methotrexate controlled him, but he got these infections. He won't go there, so my control and delete list is the same. What's the alternative list? The alt thing. Otezla, we tried that, didn't really do anything. Haven't used other drugs for which you might be using an off-label indication, something like tacrolimus or mycophenolate, cyclosporin, which actually is an indication for. This is what I decided. I offered the man to take daily injections of anakinra or every 8-week injections of canakinumab, an IL-1 inhibitor. They have been associated with joint infections or serious infections. We just don't use as much of that drug. And I like canakinra. It's a short half-life drug given once a day. It is approved for use in rheumatoid arthritis. The canakinumab long-acting IL-1 inhibitor is not approved for use in rheumatoid arthritis. In fact, it didn't work in rheumatoid arthritis in clinical trials. What else can we give him? We could also give him a JAK inhibitor. Do JAK inhibitors have a very high rate of serious infections? They generally don't. It's really what the zoster infections we're worried about most. And so that was a choice. Daily injection versus daily pill. He wanted the daily pill. Oh, and by the way, he only has Medicare, and neither of those are covered. So we're going to go with a JAK inhibitor and try to start out with some samples, try to get compassionate use, or he has a secondary insurance that might cover it. If that doesn't work out, then we'll go with the daily anakinra, We're going to have to apply for patient assistance through the foundation. Again, these are really difficult, but when you have difficult cases, you go to that Control-Alt-Delete solution. I think that works for a lot of people. And he really does have swollen joints, so I'm forced to do it. The bottom line here is a man who's at high risk for infections with rheumatoid arthritis, what's your best choices therapeutically? Number one, get off steroids. You shouldn't be on steroids. Number two, methotrexate, sulfasalazine, hydroxychloroquine seems like you're doing something without really doing something bad, like starting an expensive, possibly dangerous biologic. Abatacept would be the first choice. I think it has the lowest infectious risk of all the biologics. However, that was tried, couldn't take it, won't take it. Now we're just left with either a low dose of a biologic, that's why I went with a short-acting anakinra with a half-life of 6 hours, and I don't know that it's really appropriate risk, but appropriate choice given the risk, but a JAK inhibitor might be the solution here, especially if you can get control and use less drug or half dose. But again, above all, avoid the steroid. That's it. Hope you enjoyed the meeting. You give us 2 hours, we'll give you the ACR. Should be fun.